So welcome everybody. My name is Michelangelo Mancuso. I'm the co-chair of the mitochondrial working group of the EURO-NMD. And today we are going to deliver the fourth webinar we have organized during the World Mitochondrial Awareness Week, which every year is in September to raise awareness and knowledge in these rare disorders. So this is the last of the four webinars. The previous three are available on either the EURO-NMD webpage or on the YouTube. So if you want to listen to them, if you lost them. And now the last one, it will be presented by Serenella Servidei. She's the chief of the neurophysiology unit at the Policlinico Universitario Gemelli, the University Hospital Gemelli in Rome. She's a very active member in the EURO-NMD, not only on mitochondrial diseases, but in a lot of other neuromuscular conditions. And she's one of the most, prepared and very well-known neurologist working in the mitochondrial medicine field. So she will cover the topic of MELAS and MELAS spectrum disorder, from the clinical findings to the management. You will have the possibility to post your questions in the chat, and at the end of the webinar we will have some time to go through the questions on the chats, and we will take care of them. So Serenella, the floor is yours, and enjoy the webinar.
Thank you, Michelangelo, for your nice word. Thank you, the European Reference Network, to organize this series of meetings. And my topic is MELAS and MELAS spectrum. I will show you some clinical case because about MELAS there are many papers, many ideas. So there is a lot of still confusion, even if I think it's the best known of mitochondrial disorder. So I will start with this patient. He's a 22-year-old man that presented to the ER for a first generalized prolonged seizure. The 4 days before, he had fever and headache. The past history, there is a mild cognitive impairment, no better defined. In the ER, neurologic examination showed no focal deficit at all. This is the CT scan showing a right temporal parietal lesion, and the diagnosis was stroke. So is this possible that such large lesion does not cause focal deficit? This is the first consideration. And in the following days, other generalized seizure, several generalized seizure, and this is the MRI after 3 days. And you see the confirmation of this large region, temporoparietal insular area, DVY positive, but with surprise, we can see also another lesion in the right hemisphere, and this is just one point to make some reflections. And again, completing the MRI study, you see that this lesion, the parietal, temporoparietal is DVY positive, and the cerebella is DY negative, and that means these the different timing, and also by perfusion there is hyperperfusion, and by spectroscopy you can see very well the lactate peak. So you can advance the hypothesis of MELAS. That is was confirmed in fact genetically. But what does it mean, MELAS? The first definition of this acronym was by Pavlakis in 1884. Mitochondrial myopathy, encephalopathy, lactic acidosis, and stroke-like episode in Annals of Neurology. he defined this distinctive clinical syndrome. And he described the association of an encephalopathy, a mitochondrial myopathy with ragged red fibers, and recurrent cerebral insults resembling stroke. Some years later, Goto described the first genetic mutation in Nature, 1990, because this was the beginning of the mitochondrial medicine era. It found in this patient, this distinctive clinical syndrome, the presence of a mutation, the 3243, the famous 3243 mutation in the tRNA leucine. But to have the first diagnostic criteria, we have to wait years later, 4 years later, 1994, published by the group of Dimau and Roland. First of all, it was not anymore mitochondrial encephalopathy, but encephalomyopathy. And the diagnostic criteria was stroke-like episode with onset before 40 years, encephalopathy characterized by seizure, dementia, or both, lactic acidosis, ragged red, or both. And over time, there were many definitions, many criteria, Japanese criteria, various criteria. The last one, updated diagnostic criteria, was from a consensus-based statement. Also, Michelangelo took part to this consensus, and with the definition of stroke-like episodes. What are stroke-like episodes? Subacute evolving brain syndrome driven by seizure activity in genetically determined mitochondrial diseases. These are potential treatable encephalopathic episodes that can present at any age, so no more before 40 years, with neurological and/or psychiatric symptoms typically associated with cortical, subcortical MRI changes and EEG abnormalities. So the update diagnostic criteria are the clinical feature that I said before, the MRI lesion, typical stroke-like lesion, non-vascular stroke-like lesion, EEG showing focal epileptic discharges, genetic defect recognized to cause stroke-like episode, other differential diagnoses such, first of all, in premise ischemic stroke and also viral encephalitis excluded. So the first three criteria, okay, but we have also other possibility to try to make the diagnosis or faster, or the fastest possible. The laboratory that showing oxidative metabolism dysfunction with lactic acidosis at rest after exercise, decrease of oxygen consumption during effort, reduced muscle working capacity. The muscle biopsy was not anymore included in the diagnostic criteria, but I think in some cases may be still useful. I will show you this in the last case. The biochemistry that shows partial defect of respiratory chain enzymes, and detection of heteroplasmy level for mitochondrial DNA mutation. Heteroplasmy level in blood, muscle, so the useful of muscle biopsy, and urine. Heteroplasmy is the coexistence. In the previous episodes, Mika Martikainen explained very well what is mitochondrial transmission and heteroplasmy. See the coexistence of wild type and mutated genome in the same mitochondria, in the same tissue, various distribution in the different tissue. And the first question, correlation with severity of the phenotype. After many years, the answer is not so clear. Depends on the series. There are many reports with small, large series with different conclusions. And more recently, the group of Gorman says also that 3-4-3 heteroplasmy, age adjust 3-4-3 heteroplasmy in multivariate analysis associated with BMI, sensory neuron loss, and serum lactate were significantly associated with risk of stroke-like episodes. So the most common central nervous system clinical manifestation are, of course, stroke-like episode, above 90% of the patient, epilepsy, 70-96% of the patient. This depends on the different series of clinical case. Cognitive and psychiatric problem, up to 90% of the patient. Migraine, 50-90% of the patient. But this is a multi-system disorder. Intolerance to exercise, lactic acidosis are part of the acronym, so they're always present. Myopathy or progressive sternocleidomastoid myopathy, diabetes, neurosensory loss, cardiomyopathy, gastrointestinal dysmotility, metabolic decompensation, and so on. The most common genetic defect is the famous 3243 AG mutation, but this is account for about 2/3 of the patients, but also autosomal recessive POLG mutation, about 20% of the patients, and other more than 30 mitochondrial DNA point mutation. So stroke-like episodes need to differentiate it from ischemic stroke, and because they have a special management, they cannot be treated as ischemic stroke. And which are the characteristics? Lesion evolve in days or months. These are cortical and subcortical areas with no vascular distribution and migrational behavior. This is, for example, the evolution of this lesion, the lesion over from day 2 to 120, so over 4 months. There is increased perfusion, another important concept. The lesions are the white, bright, with mixed pattern. Increase, that means vasogenic edema, and restrict, cytotoxic edema, on EDC map. Since the early stage, and this is very important in differential diagnosis versus ischemic stroke, in which by EDC map, there's only cytotoxic edema. Then some cortical lesions turn in pseudolaminar necrosis, gliosis, and atrophy. In our cohort of patients, 63 of stroke-like episodes followed migraine, and 75 were associated with seizure. Age at the first event in our series is from 8 to 61 years. Attacks involve occipital, mainly parietal, temporal, and frontal lobe are quite spare instead. Acute, what is interesting is that acute lesion were bilateral in 66% of stroke-like episodes, and symmetric at the onset in 51%. What does it mean? That is a very high incidence compared with vascular stroke of bilateral clinical syndrome. That means auditory agnosia, cortical blindness, prosopagnosia. And this is an example, a 36-year-old woman that in May 2004 had suddenly reduction of hearing. She thought at the beginning that it was because she had neurosensory hearing loss. She thought this I'm bad because this is got worse, but instead, no. It was a stroke, a bilateral stroke involving temporal lobes. And the DVI showed that these are both acute lesions. The ectoplasmic level in muscle was 50%, not so high. So the pathophysiology of stroke-like episodes is clearly different from the one from vascular stroke. There are various elements that can be there are concurrence to in the manifestation of the stroke-like episodes. One is obvious that mitochondrial angiopathy, although this is not a relevant factor, but there is alteration in small vessel in muscle with increase of abnormal mitochondria, very strongly SDH reactive. And the same feature we can see in the brain. And in this paper by Betts, various years ago, 2006, they found that the mutational load was more elevated in brain, almost 100%, than in neurons. This finding, anyway, was not confirmed in, another big group, the group of Gorman, didn't confirm completely this finding because they say neurons harbor more severe mitochondrial respiratory chain deficiency than vessels. So they didn't study ectoplasm, but the significance is the same. I mean, neurons are more affected than vessels. Another important factor is that there is no reduction in blood flux like in ischemic stroke, but there is hyperperfusion and normal angiography. Why hyperperfusion may be related to metabolic stress-induced vasodilatation, because in this area, I showed you before, there is a very high peak of lactic acid, and lactic acid is a vasodilator, and a reduction of N-acetyl aspartate, meaning that neurons are ill neurons. They are not efficient. Another very important factor implicating a dysfunction of neuron is that paroxysmal events are common of the onset of stroke-like episodes. In our series, focal, mainly motor, or generalized seizure were present 44% of the patient, but in 75% of stroke-like episodes. And we all know that epilepsy influences morbidity and mortality in mitochondrial disease, and even more in MELAS patients, because there is like a vicious cycle with deterioration after period of persistent seizure activity, neuronal energy deprivation. These neurons were already deprived of energy. Neural injury, cell death, further seizure, progressive epileptic syndrome. So you need rapid, aggressive treatment of seizure. And this is an example. This is a patient with MELAS. He had cognitive impairment, and he came to emergency room, 30-year-old patient with a ectoplasm 80% in muscle. He came to the emergency room because of psychotic disturbance. A few hours later, he started to have this focal status epilepticus. The CT scan before was normal at the beginning. After these episodes, the CT scan The control CT scan showed this lesion in the frontal area that was confirmed and persisted 3 weeks later by MRI. You can see also hypertrichosis, that is a common, not hypertrichosis, but endocrinological disturbances are common finding in MELAS patients. So, pathophysiology of stroke like in synthesis, in summary, there is ischemic mechanism based on mitochondrial microangiopathy, blood dysfunction, and vasogenic edema, but a primary metabolic mechanism sustained by neuronal energetic dysfunction, a toxic effect of lactic acid. But the more important mechanism is non-ischemic neurovascular cellular mechanism with neuronal hyperexcitability, and that you have to stop to get improvement in this patient. And the fourth mechanism, not yet demonstrated, is the possibility of dysfunctional neuroinflammatory response to trigger involving neuronal, vascular, innate immunoprocess, as demonstrated in some epileptic syndrome. This causes, of course, a TP depletion and neuronal cell death. I said before that 20% of the patients have autosomal recessive POLG mutation. This is a 19-year-old girl that showed progressive bilateral reduction of vision that turned out was a cortical blindness, again, bilateral neurological syndrome, and epileptic seizure. She slightly improved with steroid, but very slightly. And then she showed progressive ataxia and seizure again. MRI shows a bilateral involvement of the occipital lobes that explain the cortical blindness and cerebellar atrophy. What is important to note that spectroscopy is different from the one of MELAS patient, because in this patient we have the peak, lactate peak, only in the affected area, like in the ischemic stroke, but are not ischemic stroke because the DY are positive but with normal ADC, but the spectroscopy is normal in normal brain areas in CSF. In general, individuals carrying POLG variant have their first stroke before age 20 and show a more aggressive disease. This patient, I saw her just today, this morning, did improved. MELAS patient, they completely recovered from their acute neurological deficit. And is still going on with the worsening of ataxia. So in general, POLG stroke-like are more aggressive and with higher risk of death from status epilepticus. So stroke-like therapy. I said stroke-like are different from ischemic stroke and require special management. In the acute phase, first of all, likely, we stop the use that was going on for years and years, I think still in use in Japan and maybe in the United States, the intravenous arginine, because there was a Cochrane review saying that intravenous oral arginine confers no demonstrable clinical benefit in either the acute or prophylactic treatment. There are not enough data on possible risk of adverse events. Studies were not standardized, and there is a need of methodologically robust trial. So no arginine, even because there is not rational to give arginine. Arginine should give because increase the perfusion, but here in this area, the perfusion is already higher than normal. We use, and many other people use steroids because anti-inflammatory action, anti-edema, or maybe you can use other immunotherapy, question mark. There is no evidence still now, but according to the new studies about inflammation and dysfunction of immune response in mitochondrial diseases in MELAS can be a good approach in the future. Of course, adequate hydration, but considering and actively treat seizures, lactic acidosis, infection, hyperglycemia, hyponatremia, and all the comorbidities that can be associated like cardiomyopathy or ileus and so on. And epilepsy. Epilepsy should respond to conventional anticonvulsant. And in the acute phase, you can use the IV levetiracetam or phenytoin or phenobarbital or lacosamide. In chronic therapy, you can use almost all antiepileptic drugs except valproic acid, especially in people that have POLG mutation already demonstrated, because they valproic acid may trigger fulminant liver failure and symptoms similar to Reye syndrome. And I say also pay attention to carbamazepine because it may favor hyponatremia that can be already present in patients with acute decompensation. Intensive care unit is recommended in generalized convulsive status epilepticus or focal motor status epilepticus failing to respond to benzodiazepine plus 2 other intravenous antiepileptic drugs, or seizure when associated with severe encephalopathy. But I said before that most patients, all patients, recover almost completely from focal neurological deficit. MELAS patients do not die because of stroke. So why patients with MELAS die? One possibility is the cardiomyopathy, severe, rapidly progressive heart failure in MELAS. This is a young woman, 23-year-old. She had a diagnosis of MELAS at age 21. She had a lot of stroke, seizure, but completely normal cardiac function. And a cardiac function remained normal over the follow-up period. Then at age 23, she suddenly developed dyspnea and rapidly progressive heart failure requiring intensive care unit. The cardiac MRI shows hypokinesia, diffuse, complete of the left, and marked severe of the right ventricles. There was nothing to do. And the cardiologist thought it was viral myocarditis or anyway, kind of myocarditis. We made the heart biopsy that showed the presence of abnormal mitochondrial abnormalities. This is the control to compare the pattern without any sign of inflammation. Fortunately, she died within 15 days from the onset due to cardiogenic shock and severe metabolic acidosis. Another cause is the sudden death, sudden odor death syndrome in 2G related mitochondrial disease. Again, a paper about the group of Gorman. They systematically reviewed the cause of death in 209 patients and estimate the incidence of sudden adult death to 2.4 per 1,000 persons per year. Another problem that is frequent in MELAS patients and may be present at the moment of the death is the intestinal pseudo-obstruction. This is a medical emergency, severe and often untrackable complication, because this patient go to the emergency room and surgery want to make surgery, in fact. But this no need of surgery at all. Surgery can also, by contrast, surgery can determine a worsening of the clinical situation. But they need parenteral nutrition, the compressive coloscopy, progenetic. A very good progenetic is prucalopride, because there is affinity just for gastrointestinal tissue apparatus, and it doesn't show cardiac adverse effects. But I think the most important element is the neurodegeneration. This is the patient I showed you before with the auditory agnosia. And see now, this is was 2004. This is 10 years later when she died, unfortunately. See the MRI, severe diffuse atrophy and leukoencephalopathy. At that time, she had dementia, low BMI, ileus, paralyticus, metabolic acidosis, sepsis, and death. They are like patients with Alzheimer's. They become bedridden, they are not autonomous, and they are more susceptible to infections, they are immunodepressed, they cannot eating, they have abingestis pneumonia, and so on. And this is another example. This is the mother of a MELAS patient who died at age 35, the son, and she developed, for example, the first stroke-like episodes at age 56. She had aphasia at the beginning in 2006. And this is what you see in MRI. Stroke-like episode, temporoparietal left lobes, DY positive, and another lesion in the cerebellum. The mitochondrial disorder that with onset at 56 years, heteroplasmy quite low in the blood, 35%, evolved in 7 years. She died in 7 years with progressive cognitive deterioration, psychomotor agitation, poor control, diabetes, and see the MRI here. Again, severe diffuse atrophy, brain atrophy, generalized with leukoencephalopathy. This is the old cerebellar lesion that was the same, but not active lesion, not DY positive lesion, no acute problem explain the death. And this is the progress. Here you can compare the progression in MELAS patients in the same time period, 9 years, with MERF, very visible the atrophy after 9 years, and PO associated with single deletion, no atrophy at all. The speech says MELAS, or better say 3243 related or associated phenotypes, because only 30% of the patients carrying this mutation have the classical MELAS phenotypes. The rest of the patients can have mitochondrial inherited diabetes, deafness, chronic progressive sternophthalmoplegia, cardiomyopathy, or a combination of these all phenotypes. Diabetes is a very common in MELAS patients. It's present in about, it was calculated that about 80% of carriers of 3243 mutation, 85% to be precise, develop diabetes by the age of 70. This is a 55 years old man with diabetes came at our observation because of mild instability. He had the neuropathy, but all people before thought it was a diabetic neuropathy. Instead, he had a mitochondrial disorder. And this is the MRI, cerebellar atrophy, first of all. And if you do the spectra, basal ganglia normal, basal ganglia is the one most common study by spectroscopy, small peak in cerebellum, very high peak in CSF. So when you do spectroscopy, you have to explore many areas and many sections. Here, important to note that in diabetes, it's very common used the metformin. But there is the usefulness in mitochondrial dysfunction is controversial. First of all, because metformin can cause lactic acidosis even in normal people. And then there are few reports of MELAS patients who the use of metformin causes the onset of stroke-like episodes with lactic acidosis. And peripheral nervous system manifestation, sensory axonal neuropathy, often asymptomatic, present in about 65% of the patients. Mild muscle weakness and fatigue up to 100%, but symmetric myopathy, proximal myopathy, plus minus progressive external ophthalmoplegia in about 50% of the patients. If you do MRI in these patients, you see also a specific pattern with compromission, especially the muscle in posterior part of the thigh, that is different from MERF, for example, and from patients with pure single mitochondrial deletion, which the MRI is normal. And this, for example, this is another example of myopathic patient with progressive sternal ophthalmoplegia plus cardiomyopathy. And you can see here the biopsy, muscle biopsy, the heart biopsy. They are similar. They are similar as the heart biopsy can be similar to muscle. In heart biopsy, there is focal area of accumulation of abnormal mitochondria, SDH reactive and cytochrome negative, as the ragged red-blue fiber in muscle biopsy. Heteroplasmic site, both in muscle and the heart. In this family, only cardiomyopathy was segregated in the family. Of course, besides the lactic acid elevation, only cardiomyopathy. And this is the heart biopsy of the propositus. This is the control. This is the patient, the upper panel. And you see again proliferation, very strong reaction by SDH compared with the control, but reduction of cytochrome. And the heteroplasm is very high, 90% in muscle, 94% in heart, and 55% in blood. So cardiac involvement in MELAS consists in hypertrophic cardiomyopathy, and 30% were Parkinson-White and ventricular precipitation in about 30% of the patients. Respiratory disturbance instead are not so common. In patients with central nervous system manifestation, but 3243 related myopathy are an increased risk of a respiratory problem. They can have chronic respiratory insufficiency with need of non-invasive or invasive ventilator support, or acute decompensation with epicupping respiratory failure. They have respiratory muscle weakness, they have diaphragmatic weakness that contribute to nocturnal hypoventilation and percapnia. There is incoordination pharyngolaryngeal muscle with dysphagia, and so on. You have to do a cardiorespiratory follow-up in MELAS patients with regular every 6 or maximum every 1 year, regular assessment of both aspects, cardiovascular aspect and respiratory aspect, ECG, echocardiography, 24-hour ECG, and sometimes cardiac MRI, spirometry, hemogas, nocturnal oximetry, sometimes polysomnography. And this is the last case, a passing case. This is a 62-year-old man in good health with no history of neurological disorders. He had a robotic-assisted laparoscopy radical prostatectomy under total intravenous anesthesia. On awakening, he appeared confused, disoriented, agitated, with fluctuant reduced level of consciousness. Arterial blood was demonstrated mixed respiratory and metabolic acidosis. pH 7.16, very ICK, 4,400, and was transferred to intensive care unit. So the explanation, malignant hyperthermia, ICK, but no fever. Electrolyte abnormalities, no abnormalities. Cerebral edema that can be an adverse effect of surgery in laparoscopy, CT scan negative. So what are the diagnostic hypotheses at this point? The EEG shows theta delta activity, continuous, diffuse, synchronous, and symmetric. So a diffuse encephalopathy. But MRI was normal, so central venous thrombosis was excluded, hypoxic ischemic encephalopathy was excluded, and encephalitis was excluded. So it was managed conservatively, it was not invasive ventilated, it was treated with intravenous fluids and correction of acidosis. After 8 days, it was transferred to the Department of Neurology. And she had clouding of consciousness, but then start to have episodes of confusion and psychotic disturbance, alternating with periods of catatonia or psychogenic unresponsiveness. A new EEG shows epileptic activity. The question is it possible non-convulsive status epilepticus? So start the therapy with levetiracetam plus lacosamide, start quetiapine and then replaced by risperidone, and then EEG show the reduction and disappearing of epileptic activity was still slow, theta delta rhythm, diffuse theta delta rhythm. And the clinical evaluation revealed the improvement of both psychiatric and behavior compartment. So what is the diagnosis at this time? CK level returns to normal. There is a resolution of metabolic acidosis, but there is a persistent elevation of lactic acid. And going back to MRI images, what was not seen at the beginning was this important cerebellar atrophy. So it's possible, mitochondrial disorder. So what we can do is spectroscopy. Here, high peak of lactic acid in cerebellum and CFS. And mitochondrial muscle biopsy show a clear, undoubted mitochondrial myopathy. A month after recovery, complete recovery, resolution of seizure activity, psychotic and behavior Manifestation totally clear. This is perfectly normal EOG, and the patient is still in levetiracetam, of course, coenzyme Q, riboflavin, antioxidant. So the diagnosis was acute metabolic decompensation mitochondrial encephalopathy. Genetic analysis demonstrated 3243 A2G mutation, and in MELAS can be present both convulsive and non-convulsive status epilepticus. Non-convulsive status epilepticus can be associated with psychiatric symptoms, including psychosis, bizarre behaviors, and confusion. And psychiatric features are common in MELAS, include depression, anxiety, psychosis, delirium, and prelude. Also disturbance including aggression. The tips for diagnosis in this patient: metabolic decompensation after surgery, a stressful event, persistently elevated lactic acid, edema cerebellar atrophy. So mitochondrial disorder should be included, in particular MELAS, in the differential diagnosis of acute encephalopathies, even in absence of a significant clinical medical history or the canonical mitochondrial features. At this point, can we define these patients as MELAS? He has a subacute evolving brain syndrome driven by seizure activity. He has a genetically determined mitochondrial disease associated with 3243A2G mutation, the most common mutation causative of MELAS. But he has no brain lesion on MRI. 2 words before finish about the treatment of lactic acidosis. Lactate is neurotoxic, cardiotoxic, is associated with increased risk of death. It's common to use bicarbonates that could have a theoretical rationale, but giving especially intravenous bicarbonates, there is a reduction of a lowering of pH in the serum, but a reduction of, increase of the pH, lowering of lactate in serum, so increased pH in the serum, but reduction of the intracellular pH because the increase of entrance of CO2 in the cells. There is also reduction in the concentration of iodized calcium, and reduction of tissue oxygen extraction that is pH dependent. So the use of bicarbonate must be limited only to condition of severe acidosis with a pH lower than 7.2 or for some people below 7.0. The chronic use of bicarbonate is not effective, not supported by evidence. So the chloroacetate was excluded because causes a toxic neuropathy. Continuous dialysis modalities, it doesn't seem effective in mitochondrial disorder. What is essential to do? Adequate hydration, metabolic rest, cardiovascular support, avoid or discontinuous drug that can cause lactic acidosis, in themselves like metformin or linezolid, that is a very commonly used antibiotic intensive care unit, aggressive therapy, infection sepsis, aggressive therapy, that all these situations that can aggravate lactic acidosis, such as epileptic seizure, respiratory failure, hyperglycemia, and diabetic ketoacidosis. So, in conclusion, MELAS is characterized by acute metabolic episodes, including or not stroke-like episodes, and this and a chronic neurodegenerative process. The acute episodes may occur after physical exercise, infection, stressful event, seizure, and so on. But all of them are characterized by acute heterogeneous neurological manifestation associated with lactic acidosis. Age of onset varies depending on the clinical series. 65–76% before age 20 according the pediatrician, or 1/3 above 40 according the group of Gorman. But the first episode may manifest even in older age. Our oldest patient with stroke-like episode at the onset was 61 years old. MELAS is a great example of those unstable, fluctuating genetic disorders associated with relapsing limiting episodes that persist for days or weeks, and clinical variants influenced by epigenetic genetic factors, and illustrate the trajectory, the acute risk of metabolic crisis, potential pattern, and certain in everyday life, and the chronic, steady, inexorable decline over decades, as demonstrated by progressive renator. And this is a pain that was made by the mother of 3 affected children with a mitochondrial disorder. And you see here the mitochondria and this written tiny terror. In conclusion, last slide, mitochondrial disorder in adults are mostly multisystem, and MELAS is the prototype of the clinical variability. Stroke-like episodes, rapidly progressive cardiomyopathy, hypercapnic respiratory failure, metabolic crisis with severe lactic acidosis, gastrointestinal disturbance with paralytic ileus are all life-threatening manifestations. In absence of effective treatment still now, the best cure is prevention, so early screening, adequate follow-up. All this may provide significant benefits in terms of morbidity, mortality, and quality of life. Thank you.
Thank you very much, Serenella. It was very, very, very impressive, your presentation. And it was also very interesting that you have showed a lot of real-life examples of mitochondrial MELAS phenotypes. And I was particularly fascinated by the last case with these catatonic features. And I remember also once in Pisa, we have found a MELAS 42-year-old lady that was followed in the psychiatric unit for mysterious catatonia, and then at the end she was a MELAS with a 3243 mutation. So psychiatric issues and manifestations should also raise the awareness and the possibility of an underlying mitochondrial disorder. So thank you very much. It was a great webinar.
Thank you, Michelangelo. Thank you. I prefer to choose the real life because the papers are so many, with many data, many different data. That's the problem.
Exactly. This is a good way to explain that MELAS exists. It can be everywhere. Most of the neurologists may face a MELAS patient in the ward. So yeah, it was super. Is there any question from the audience? Otherwise, in the meantime, Serenella, you were mentioning that sometimes during the acute decompensation, these patients may have acute heart failure or arrhythmia, pseudo-obstruction, gastrointestinal dysmotility. So do you recommend to always monitor, at least in a subintensive unit, this patient during the stroke-like episode, or can we manage them also in a regular unit? I would say no, but what's your impression?
If they have severe encephalopathy or very high lactic acidosis, not at all. If they have not severe seizure or severe complication, they can be monitored, for example, stroke unit, not in intensive care unit, but in stroke unit with all monitors. They should have monitors everywhere. Yeah.
I agree. Okay, I don't see any questions coming in the chats, but we had a lot of participants, so I'm very happy that the topic was really interesting for a lot of people, and pretty sure, Serenella, that your YouTube webinar will be one of the most popular of our webinar series for the Mitochondrial Disease Awareness Week. Oh,
Thank
echo.
you.
Actually, we have now a question. Should arginine be avoided in all patients, or in some patients we can use it, arginine?
In my opinion, yes, should be avoided. It's not worthwhile to give arginine in this patient. There is no support theory. These are studies that are coming especially from Japanese people. The study were done in a few patients. And if you know the history of a MELAS patient, if you follow the MELAS patient, you know very well that stroke-like episodes then disappear spontaneously. They reduce in number. The last years of the disease is characterized by, as I said, all the complications of the neurodegeneration. So, another important factor that there is no restricted blood flux in that area. So there is no meaning to give arginine. Of course, if you measure amino acid, arginine, taurine, yeah, maybe you can find low, not only in MELAS, not only in mitochondrial disorders, in many other disease, but it's not specific for stroke-like episodes or for MELAS patients. Personally, I don't give arginine to anybody.
And same for me. We have another question now, Serenella. Should metformin be avoided in case of diabetes and MELAS, or should we check for lactate?
But in real MELAS, the lactate should be high, even at rest. I don't see a patient with MELAS with low lactate. Maybe for very mild phenotype, but even in progressive sternophthalmoplegia and myopathy, I always see high lactate. I don't know your experience, Michelangelo.
Yeah, but the question is, can we use metformin to treat
Yes.
diabetes in these patients?
No, but yes, the question is, yes, it's that. But I mean, monitoring the lactate, the question, my answer, my personal experience, better avoid metformin. There are many drugs now for diabetes. Why metformin can causes lactate even in normal people? So why take the risk?
Okay, and then we have the last question because it's almost 5 o'clock. Is there any relationship between the level of heteroplasmy and the clinical manifestation?
This is a good question, and I left the question mark at the beginning. Because the results in the various series are different. For example, the Gorman group, they said that there is a good correlation with age-adjusted blood, age-adjusted heteroplasmy in blood. Because they can follow up also, because heteroplasmy probably increase over time. This is also not sure. I measured in some patients, I didn't find any increase really. Also, among the patients that I show you, that very severe case with neurodegeneration, she had a quite low level of heteroplasmy in muscle. So there is, I can say, there is a rough correlation, but not a strict mathematical correlation. Maybe in a family, you can see that the less affected people have a low lower level of heteroplasmy. But for example, I wouldn't do it prenatal diagnosis based on this speculation.
Okay, the very, very, very last question, Serenella. Do we need vitamins, cofactors, antioxidants? If yes, which ones you recommend? The Mito cocktail.
Yes, Mito cocktail. We all use, I think, in our network, Mito cocktail. First of all, because the patient wants something, and MELAS still, we don't have anything. Second, because I believe that riboflavin, coenzyme Q are effective on intolerance to exercise, not of course on stroke-like episodes that are useless, but intolerance of exercise, I have the impression that they work.
Okay, yeah, so that I agree with you. I don't see any reason to use them for the stroke-like episodes. We may have some benefit in other clinical manifestations of mitochondrial disease and MELAS phenotype. So I would say Serenella is 5:01, so it's time to close the webinar. Thank you very much for your beautiful presentation. Thank you to the participants who were with us until the very end. And hopefully next year with the ERN and the other ERN with interest in mitochondrial disease, we will organize another cycle of mitochondrial diseases webinar.
Okay.
So thank you very much.
Thank you,
take care.
the audience. Thank you, Michelangelo. Thank you, Elizabeth. Thank you.
Thank you, Serenella. Thank you,
And good
Michelangelo.
afternoon. Ciao.
Bye-bye. Ciao.
Bye-bye.
Ciao.
Ciao.